Welcome to the Bridges to Build TB in the Asian and Asian American Community webinar series. There is a pre-question poll that's up, so if you see it, you're welcome to answer it. My name's Emily. I'm working at the Korea International Tuberculosis Center. I will be doing some quick housekeeping before we start the webinar. So first, this webinar will be recorded, and so please look out for an email when the recording is posted. The Korea International Tuberculosis Center is one of the 4 TB centers of consultation, training, education. And we are funded by the CDC. This educational conference was funded by the Center for Disease Control and Prevention's Cooperative Agreement and is a project of the University of California, San Francisco. Today's presenters and moderators have indicated that they do not have any financial relationship or conflict of interest with any of commercial interests that may have a direct bearing on the subject matter. You're welcome to look at our training materials page for more information. These are the objectives for the webinar. Identify the specific barriers that may prevent healthcare providers and their Asian and Asian American patients from developing the trust and rapport needed for effective TB care, and discuss strategies to overcome barriers to treatment and improve the clinic or TB care experience for the Asian and Asian American patients. Just general tips for enjoying this virtual webinar. If you have a question, please use the Q&A chat, or you can raise your hand and we'll unmute you. We also have an online captioning tool, so feel free to use that as well. I'm happy to turn this over to our moderators, Chibo Shinagawa and Mukta Deia from the Association of Asian Pacific Community Health Organizations.
Thanks so much, Emily. Welcome everyone to the Bridges to Build TB webinar. We're here today to address the importance of addressing TB health disparities in Asian and Asian American communities, and want to definitely emphasize that next year we hope to continue this series for a dedicated series for Pacific Islanders. I'll bring it over to Deia to introduce a bit more about APCHO and T, and then I'll go back and share a little bit more about TB incidents amongst Asians and introducing today's webinar.
Thank you so much, Chibo. Hello, everyone. Welcome. Just to share a little bit more about APCHO. APCHO is the Association of Asian Pacific Community Health Organizations, as Emily mentioned. APCHO was founded in 1987, and we are dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian American and Native Hawaiians and Pacific Islanders within the United States and territories. We are a national association of 32 community health organizations serving Asian Americans, Native Hawaiians, and Pacific Islanders. APCHO also leads the TB Elimination Alliance, or T, along with the Asian and Pacific Islander American Health Forum, Hepatitis B Foundation, and Stop TB USA, with the support of the CDC. T is a national partnership of community leaders dedicated to eliminating TB and LTBI inequities among Asian American, Native Hawaiian, and Pacific Islander populations through education, raising awareness, and innovation. T launched in July of 2020, and since its inception, T has distributed over $800,000 in mini grant funding to 36 organizations. T, our members, partners, and mini grantees look forward to building on the progress that we've made so far towards TB elimination. For more information about T, please visit tbeliminationalliance.org, and that will also be put in the chat for your reference.
Thanks, Deia. As we know, Asian and Asian American communities continue to be impacted by tuberculosis at a greater rate compared to other racial and ethnic groups. I think some of you completed the poll that we shared at the beginning, which we'll go into a bit further. Countries with the highest TB burden among non-US born Asians and Pacific Islanders include the Philippines, India, Vietnam, China, Myanmar, and the Marshall Islands. In 2021, more than 7,860 cases of TB were reported in the United States. This is from the 2021 MMWR from the CDC. And in addition to that, Asian populations have the second highest TB incidence rate of 14.4 cases per 100,000 persons. Incidence rates vary widely when it comes to Asians and Asian Americans, and subgroups are and when we look at those incidence rates, they vary even more when we disaggregate them. US TB incidence increased during 2022 compared with that during 2020 and 2021. This remained lower than incidence during the pre-pandemic years after a substantial 20.2 decline in 2020 and partial rebound in 2021. Incidence appears to be returning to pre-pandemic levels among US-born and non-US-born Asian populations. These disparities are often driven by adverse effects of systemic obstacles, and we appreciate and use this research and data to remind us of what we're solving for with our TB partners and champions here today. This can help us reduce and ultimately eliminate these disparities so that our communities can be free of TB and achieve health equity.
Thank you, Chibo. With that said, we will begin our presentations for today. Our first speaker is Dr. Julie Higashi. Dr. Higashi is the director of the TB Control Program for the Los Angeles County Department of Public Health. She will be speaking in the context of the U.S. Asian population and the cultural or social factors that might influence the effectiveness of TB diagnosis and treatment. Dr. Higashi.
Thank you so much. So I'm really setting the table for the discussion. And one thing I do want to note is that I'm focusing on the Asian American population in the US affected by TB. And this is distinct from the Native Hawaiian Pacific Islander population. So I think most of you know that TB is a deadly disease. Prior to COVID, it was the most deadly infectious disease killer in the world. That all changed with COVID, but actually TB deaths during COVID continue to rise. And in 2020, 2021, we saw increases. In 2022, I think it's debatable whether or not COVID versus TB is the #1 infectious disease killer. It's not something that you really want to be #1 in, but we expect that TB will take that sort of #1 position in the near future, unfortunately. It is important to note, though, that TB is a treatable and preventable disease, and these interventions can be quite effective. And so we have saved millions of lives in the past decades from proactive intervention. So just as a little bit of a background, I think most people are aware that TB is an airborne disease. We're very familiar with this concept because of COVID, and that if a person has TB in the lungs or the upper respiratory tract, which is the most common form, although TB can impact any sort of organ in the body, those microparticles that are coughed into the air are able to stay suspended if there's not great ventilation for hours. And so that's why it's always safer to go outside for an airborne disease if you're encountering a person or situation. But this is how TB is transmitted, and it's really hours of breathing in those infected air particles that produce the conditions which folks may become infected or progress to disease. So generally, when people are exposed to TB, not everybody is going to develop infection, and we have to go through a process of evaluating folks in order to understand what to do. And so two things can happen. About 30% or so of people who have what is considered a significant exposure will become infected. A small fraction of those people will actually go directly and develop the deadly form of disease. The most people will develop a latent TB infection. And this is a condition in which the immune system takes control of the infection, walls it off. And most people actually end up walling this infection. It isn't a problem for their entire lives. A small fraction will reactivate. That's the 5%. And the fortunate issue is that we don't know who will progress and reactivate and who is going to remain latently infected. And so there's an opportunity in latent infection to do the preventive treatment. That's an intervention, and get rid of the infection, and therefore that person will progress. What COVID has done is made things even more uncertain as far as how these processes and the likelihood of them are going to happen. So if you do have COVID and latent infection, maybe that might push or increase the risk of progression to TB disease. We don't know. If you have coincident infection with TB, we know that a COVID infection, we know you're more likely to die. There are a lot of issues. And then COVID also impacts the immune system. So these are things that we will be dealing with. And because the Asian population has a higher risk of latent TB infection than other populations, they're going to be impacted by these changes related to COVID. All right, so this is an epi curve of TB in the United States. And you can see that in the 80s and 90s, there was an increase that was related to the HIV/AIDS epidemic. Then we saw resources pouring into public health, and that helped reduce the disease incident for TB over a number of decades. We had a plateauing out in the late 2000s or in the last decade, and then this decrease that Chibo just described. And we're seeing now a rebound. I want you to look at the 2.4 per 100,000, and that number, just keep that in your mind, because that's the case rate for TB of the general population in the United States. And then at the way bottom, you see this blue dotted line, and that's the elimination threshold. That's where we would hope to see at some point us TB being eliminated. And so you can see we're very far away from that. Okay, this is just a graph to show the number of deaths as far as deadly disease in the US. And so typically, in 2020, there were 600 deaths. It takes a few years for us to know the number of deaths related to a particular year that TB is reported. This translates to about a 10% death rate in the United States. This is a graph that looks at the nativity, so folks that are born outside versus in the US as far as the breakdown between the disease incidence. And you can see that there's been a change over the last decades to having a more likelihood or risk associated with nativity. Because the Asian population is more likely to include individuals who are not born in the US, the Asian population has a higher risk for having latent infection and TB disease. And basically the breakdown right here is 71% non-US born versus 28% US born. And here you can see that rate 12.5 per 100,000. So that's 4 to 5 times what the general population is. By virtue of the fact of that nativity status, our Asian population is going to have a higher risk for TB. So this is my first sort of question, which is what are the top 5 countries of origin? And I think Chibo gave you a little bit of a preview. That report US TB disease incidence. And again, these are not necessarily the countries with the highest rate of TB, but these are the folks that would be in the United States. All right, so I'm gonna keep going here. But the answer is Mexico, India, Vietnam, Philippines, and China. And so you can see that out of the top 5 countries, 4 of them are Asian countries, and they are contributing these disease incidents to our US TB reports, and so therefore reflects a burden or risk for our population. All right, so this is a graph of the United States and the distribution and as far as the case rate. And the darker blue means there's a higher case rate. But I think the important thing to note here is that if you look at the cutoffs, which are 20.8 versus 22.3, that's not a lot of difference. And so there's a health equity goal by 2025 to get the United States below the 20.8 per 100,000 case rate. And so what does that mean? That means that we're talking about a case rate that is almost 10 times what our US population, general population rate of TB is. So even on the lower end, we're still seeing quite a high burden of TB in our Asian population. And so even though you have a gray dot there, it still means that there's a disproportionate risk for the Asian population. This is another way of looking at case rate and as compared to other race ethnic groups. And the Asian population is in the blue dotted line. So you can see that it is almost nearly at the top of the case rates for non-US born individuals. And then the US born, the spread is much bigger or smaller between the race ethnic groups. And so we're in the middle, the Asian population, US born, in the middle of that group. When you break it down by percent, then you can see that it is a 48% of the Asian disease incidence of non-US born persons and is the largest percentage in non-US born, so in immigrants. And then for US born, not so much, or very much reduced percent relative to the other race ethnic groups. So nativity is really a driver for TB infection and TB risk in the Asian population. And this is another way of looking at this. Again, I'm sort of burning into your mind. We have a case rate for non-US born Asians of about 24 per 100,000, which is about 10 times what the general population rate is. And then once we get to the US born Asian population, it's much less and very comparable to the other race ethnic groups. All right, so this graph is different in that it really looks at the percent of race ethnicity attributed to transmission in the United States. So we, for every lab confirmed disease incident for TB, those isolates are genotyped or sequenced, and we can track between two individuals whether or not there was transmission between those individuals. And what the bottom line here is that when we think about disease incidents, recent transmission is not as much of a factor for the Asian population as 7%, either from 2018 and between 2018, 2019 through 2021. And so therefore, transmission on the ground is not the predominant way that we're seeing TB be impacting the Asian population. So here is my second polling question. You've got some data. So what do you think are strategies to improve TB outcomes for our US Asian population? Is it effective TB evaluation and treatment for new immigrant arrivers by local public health TB programs? Those definitely exist. Is it scaling up TB evaluation and treatment for TB infections for at-risk Asian population provided by the primary care provider? Is it raising awareness of TB as a health equity issue? Or is it all of the above? So it's D, at least that's my opinion. And I think, taking all that data that I just talked about, what comes out of it is that there is a certain portion of our TB that is coming from, new arrivers that are from Asian countries. There's a certain number that are recent transmission, but that is not the predominant way. And I think overwhelmingly what the data are showing is that most of what we're seeing in our Asian population is going to be reactivation disease. So this is opportunity to prevent, opportunity to intervene before someone ends up getting a deadly disease. This is just the steps of scaling up diagnosis and treatment of latent TB infection, which is elimination activity. And so there are multiple steps along that cascade. I'm not going to go into it, but let's keep going. And so just sort of in short, I'm hoping that what I was able to convey was TB as a global health threat. We're at a particular time that the Asian population can be impacted because of progress lost during the COVID-19 pandemic. We do not think that reduction in TB disease incidence had anything to do with understanding what the morbidity is in this country. And for example, in Los Angeles, we saw a reduction in Asian TB reported, and that has come back. And I think that's because those disease incidences are very sensitive to global travel to and from Asian countries. And that TB disease, it continues to be a deadly disease and disproportionately impacts the US Asian population. Finally, we can do something about this. And my sort of take is that we can most effectively do this by scaling up diagnosis and treatment of latent TB infection. Thank you so much. This is our Los Angeles County TB program at one of our first in-person events after the pandemic. You can see us all in our masks. I want to thank the partners that I have on the slide that have helped us get through the pandemic as a program and continue to move the ball forward for TB elimination. And want to acknowledge primarily the CDC Division of TB Elimination for the data that I presented today. Thank you.
Thank you so much, Dr. Higashi, and just for sharing all of that data, providing a little bit more context for today's presentation, and also the importance of really scaling up I'm happy now to introduce our colleagues at the Northeast Medical Services. Deia Dawn from the Immigrant Health Program team. She's an Immigrant Health Program Associate, along with Dr. Amy Tane, the Director of the Immigrant Health Program at Northeast Medical Services. They will highlight and affirm our commitment to equity through disaggregated data collection.
All right. Hi, everyone. Are you able to see my screen okay? Okay, great. Hi, once again, I'm Zinnia. I'm joined with my colleague, Dr. Amy Tang, and we're from Northeast Medical Services, a community health center in San Francisco. Today, we'll just be talking a bit about how we collect disaggregated data and how we utilize that to understand what health disparities exist within our patient population. So here's the agenda. A brief introduction to NEMS. We're a private nonprofit community health center serving the San Francisco Bay Area. NEMS has been serving the community since the early 1970s. Today, NEMS is a federally qualified health center and serves roughly 69,000 patients on an annual basis. To give an overview of our patients, roughly 90% identify as Asian, with 80% being better served in a language other than English. Roughly 80% have Medicaid insurance, with 6.5% being uninsured, and a little over a quarter are 65 years and older. Here's a breakdown of our patient population by race and ethnicity. And what I want to invite you to think about is that if this was all that we had to illustrate our patients, it would be a very diluted view compared to how colorful I know our patients to be. So it's really important that we do collect disaggregated data, especially when we serve such a large homogeneous Asian population. So I want to go into a poll question just to see among our audience members, does your organization currently collect more detailed ethnicity data beyond are you Hispanic or Latino? And I'll probably do 5 seconds, 5 to 10 seconds. Okay, great. Wow. So I'm seeing roughly 70% say yes, 25% say no, and a little over 5% say, I don't know. I'm able to share. Great. Okay, so thanks for participating in that. So at NEMS, we collect beyond race and ethnicity information. We also collect place of birth, region of birth, ethnicity detail, and preferred language. Region of birth, and so all of these fields are information that's collected during our member registration and then revisited on an annual basis to provide an opportunity to fill in that information if it's missing. Region of birth is something that we collect, which is a required field if our patients select China as their place of birth, since many of our patients do indicate that their place of birth is China. Similarly, if a patient selects Asian as their race, ethnicity detail is a required field for them to kind of further indicate what ethnicity they identify as. So outside of that, though, they are optional, but if they do select China or Asian, then region of birth and ethnicity detail are required fields. And so just wanted to give a brief glimpse of what that looks like. So you can see that here. So you can see place of birth and region of birth is collected up top. And then here's the template for ethnicity details. And then moving on, I just wanted to share an example of how we utilize preferred language in the context of TB screening. So these are result letters that are automated and sent to directly mailed to the patient. And currently we have these letters available in English, Chinese, Vietnamese, and Spanish. Now, I understand that some or most health systems collect preferred language, and some may even use it to kind of approximate place of birth information. However, sometimes that could be misleading. An example I want to give is our adult patients who indicate Vietnam as their place of birth. And then what you're seeing now is the graph that showcases their preferred language indicators. And very interestingly, we see that 40% indicate that Vietnamese is their preferred language, with 45% indicating Cantonese, which is a Chinese dialect, as their preferred language, and then 14% indicating English as their preferred language. So this just kind of goes to show that, well, first, there's a lot of complexities when we are kind of looking into and learning more about populations that experience double migration. And this kind of just alludes to the history of Chinese Vietnamese refugees. So something to keep in mind when using preferred language. Now, I do want to tie in how collecting place of birth can be very meaningful in terms of, well, in the context of working towards TB elimination. So as mentioned, NEMS serves the San Francisco Bay Area, and we have clinics serving the San Francisco, San Mateo, and Santa Clara counties. And so these counties also have very high TB incidence compared to the state of California, as well as the country. And if we're looking at TB incidence in San Francisco by race and ethnicity, we see that TB incidence is almost 10 times higher in the Asian Pacific Islander populations compared with non-Hispanic white populations. And nearly 90% of San Francisco's TB cases are among individuals born outside of the US, with a large proportion being born in China. So all that being said, NEM serves a very high-risk population for TB infection, which is why it's so important for us to collect disaggregated data, in particular, place of birth. So now I'm curious to see whether your organization collects place of birth information. And we'll do maybe 5 to 10 seconds. Oh, wow. Okay, let's see. I'll do a few more seconds. And I'm going to stop the poll now. Well, this is super cool. We're seeing a little over 80% saying yes, that you do collect place of birth. Well, that's awesome. And then we have 11% saying no, and then 6% I don't know. So I'll move forward. Well, I'd like to share kind of how we utilize that place of birth information at NEMS. So as mentioned, we collect place of birth information during member services, registration, and if there is a place of birth that's outside of United States, Canada, Australia, New Zealand, or Western Northern Europe, we actually have an automatic notification that prompts the provider that their patient is at higher risk for TB infection and that they should place in a TB screening order if one has not been done in the past, and also have the patient complete the risk assessment, which you can see here on the screen right now. And we also have place of birth, region of birth, and we also collect here in the United States up top, which is shown in the TB risk assessment. So shifting gears a bit, I just want to talk briefly about some examples that our team has participated in to kind of understand the health disparities that might exist within our patient population. So this first one is a paper that was published earlier this year looking at TB testing and treatment initiation trends at NEMS over the past, over a 10-year time period. I'm only going to give some highlights due to time constraints, but I invite you to read this paper after the webinar. So what we found was that approximately 125,000 patients had an encounter at NEMS between 2010 to 2019. 40% completed a TB test, 80% had place of birth outside of the US. We found higher TB testing rates among Asian, Cantonese speaking, and foreign-born patients. Of those tested, 20% had a positive TB result, and 46% of those with a positive TB result initiated treatment. And interestingly, we found that Vietnamese as preferred language had higher odds of treatment initiation compared to Cantonese. We also had to utilize different ways to categorize non-US born, since at that time, our workflow to collect place of birth information was just recently implemented. So we didn't have full data at that time. So we also had to use data of entry to the United States as well as preferred language. This table here we did not include in the paper, but I think it's very interesting, and I wanted to share this with the group here. to kind of showcase how you can utilize this information if you have it. And so what we see is that compared to the overall population, those born in Vietnam and Myanmar, of course, China, Philippines, Hong Kong, had a higher positivity rate compared to the overall population. The next example that I want to speak briefly about is at the onset of the pandemic, there were a lot of reports on higher mortality rates among Asians in San Francisco with COVID-related deaths. And still to this day, there is a disproportionately high COVID-19 related death rate among the Asian population. So we wanted to kind of dig deeper to understand what potential factors that might be influencing that. At NEMS, we don't collect, or we don't have, kind of a consistent way of capturing hospitalization or death outcomes data. So our analysis primarily focused on associated demographic factors and characteristics of COVID-19 infection. But we did a retrospective study looking at patients who completed a COVID-19 PCR test. And very interestingly, we found that Vietnamese language preference and Vietnam as place of birth showed higher odds of COVID-19 infection. And once we had this data, we were able to actually partner with a local nonprofit community-based organization focused on the Vietnamese immigrant community to decrease testing and treatment barriers, as well as linkage to care at NEMS. So kind of an example of how we're able to utilize the information and implement it to impacting the community. Next, I'd like to pass the microphone to Dr. Tang to speak about her research with hepatitis B.
Thank you, Zinnia. Hi, everyone. I'm Dr. Amy Tang. I'm the physician lead for our Hep B and TB programs. And prior to coming to NEMS, I used to work at another health center in New York City called Charles B. Wong Community Health Center. And I wanted to showcase this paper, even though it's not about TB specifically, it's about hepatitis B in the Asian immigrant population there in New York City. I think it can really highlight what you can do with this disaggregated data. So Zinnia mentioned that NEMS currently collects region of birth and place of birth or country of birth. And one of the reasons we decided to start collecting that at registration is because we were getting incomplete information by having to only collect it in the TB risk assessment. And I noticed a lot of you said you do collect place of birth, but my guess is for some of you, it's only during a TB risk assessment and maybe not for all of the patients at your health center. So like NEMS, because Charles B. Wong saw a very large Chinese immigrant population, we collected region of birth. And that's where a lot of this data really comes and becomes really colors this the research outcomes that we're able to see in this study. So this was 20 years of Hep B screening data where we looked at people who were tested with the 3 serology panel, which looks at current infection, prior infection, and then level of immunity. And we're able to come up with this table here that really focuses on place of birth, age, range stratification. And then for China, we were able to kind of go down into region of China. And so the next slide, I know this is a lot to handle. So the next slide just really highlights some key findings that I wanted to highlight for you all. So looking at patients who had ever been infected, which is looking at the core antibody, so that's a marker of Hep B exposure. In China, you can see it's as high as 71% of our patients screened had been infected with Hep B in their lifetime, and it was much lower, 5.6% for US-born patients within this age range of people who had been in that cohort who were starting to get vaccination. And then if you can go back to immunity from vaccination was also higher in the US compared to China. And a lot of that might have to also do with prior exposure and endemicity. Next slide. So for, again, looking at ever infection, which is reflected by a positive core antibody, if we looked at place or country of birth, you can see that the rate was highest for China, followed by Vietnam, Taiwan, Hong Kong, and etc. So very different for each, within the Asian countries, there were stark differences. But if you break down for province or autonomous region within China, you see also very big differences. So there's a very large Chinese immigrant population in New York City from Fujian province, and specifically around the Fuzhou capital city area. And we had found that the prevalence of chronic Hep B and ever infection was extremely high in that population, almost 75%, compared to a little bit lower for Guangdong province, which is probably the main area of China migration for the San Francisco Bay Area region. So you can kind of see how these migration patterns and then of course prevalence of having diseases like chronic hepatitis B or TB will vary depending on which immigrant populations are coming from which regions. And so this was, I think, one of the first studies done in the US to really illustrate some of these very specific regional differences in Hep B prevalence. Next slide. And so we put this together on a map of China. So for those who are familiar, you kind of see this, people describe China as looking like a chicken. So the belly of the chicken, as we see here, is the south east region seems to kind of have the cluster of the highest prevalence. And so Fujian province actually is right across from Taiwan, which also has a high prevalence of hepatitis B. And then you can kind of see it radiate outward, and it's a little bit less in the northeast region. So this was like a really fun and interesting research project to put together, and a great example of what could be done with our TB data in the future once we accumulate all that regional data over time. Next slide. So moving forward, we are actually switching to Epic, from NextGen to Epic, in just a couple of weeks from now. And so we've been working hard on designing and making sure we continue to collect this disaggregated data. And we're also planning to collect detailed ethnicity data outside of Asian race. We aim to get 100% completion of this data collection and continue advocating for data disaggregation of AA and HPI data, because this is important for, for advocating for resources and things like that, and looking at health disparities in our community. So some concluding thoughts for you to think about is, what information is your health center or your health setting using as a surrogate for place of birth, and how good of a proxy is it? And that granular disaggregated race and ethnicity data should be adopted not only by the research community, but also the public health community. I know a lot of you on this call are working in public health. Want to acknowledge all the people on this slide. A lot of them we worked with on CDPH for the 10-year retrospective paper, and of course our local Department of Health. I want to give a shout out also to Dr. Higashi, who back in 2013 worked with one of our physician leads on really starting NEMS really focus on TB prevention because of all the cases in the city. And then of course our own internal administrator and analytics team, and Charles B. Wong. Thank you.
Thank you, Dr. Tang, and thank you, Zinnia, for your presentation on the importance of how we can address health equity through disaggregated data collection for the diverse communities for Asians and Asian Americans. Next, we will transition to Monica Chandal, TB survivor and advocate from We Are TB, to hear about her experiences as a TB patient. Monica.
Yeah, hi, I'm Monica. I'm Monica. I'm a PhD student at the University of California, Santa Cruz. And I'm also a person who had TB or a TB survivor. And I'm just going to talk a little bit about how I found out I had TB, my experience with TB, and what's happened hereafter. So I am originally from Canada, but I had moved to the US for, my PhD, and in doing so, I had to do a TB test or a TB skin test. And in doing so, I sort of found out that I had TB because at the time of the TB test, I was a very healthy individual who was going on runs, going to spin class. But apparently I had a bunch of holes in my lungs, and I had active TB in the past. So I have a history of traveling. I used to work in Malawi in India. So in my most recent trip, when I went to Malawi, I did end up getting very, very sick. It was at the same time that the COVID pandemic was starting, and countries were shutting down, airplanes were closing. So I went to the hospital, thought I had COVID or malaria or something. All of the doctors sort of deemed me as clear. I did a blood test. I did everything I needed to do, but I still felt really sick. I ended up traveling home. My parents, due to the Canadian quarantine policies, had kind of locked me in the basement. But that ended up being really good for them because nobody ended up getting sick later. About a year and a half later, I had to do the skin test for my visa clearance, and I had gone to a travel clinic. You know, the travel clinic was like, oh, your skin test positive. You just need to get an x-ray. Don't worry. We've never had an active TB patient come to this clinic. It's probably just latent. You'll be fine. Unfortunately, that was not the case, but I was immediately forwarded to the TB clinic in Edmonton, Alberta, Canada. And from there, it was sort of like a 10-week journey to figure out what I had, because again, I was really healthy. I have no recollection of like traditional TB symptoms of, you know, coughing up blood or anything that I had read or seen on the news or when I Googled what was TB. So the initial doctor I was assigned was actually really nice. She took a lot of time to explain what my problems were, what tests needed to be done, and what the outcome of each test would sort of lead to. So in doing so, she made me feel very secure in what treatment I was getting and that my doctor understood what my problems were. So for example, if we were going to do a blood test, she would tell me exactly like this blood test is testing for ABC, and then if it's positive for like A, we're going to go down this route. If it's positive for B, we're going to go down here. So she was really, really good at explaining to me and, you know, listening to my questions and not making me feel like a burden, which I had previously felt like at other doctors, if you asked a lot of questions. So maybe it was like a function of the fact that this was a TB specific clinic, but they were really good at sitting with me and explaining everything. And that ultimately made me feel like somebody was on my side, and like felt like she was doing right by me. And I was actually deemed clear of TB before I found out that I actually had TB, because my cultures took around 9 weeks to grow. But luckily, you know, which gave me a little bit of false hope, but at the end of the day, I did start my TB treatment in Canada, and then I moved to the US after 2 months. And then within the US, I did around 10 to 11 months of prolonged care. So then once I came to the US, my doctors sort of sent me with like a binder of all of my results and told me, go find a doctor in Santa Cruz and they should be able to help you. You know, yes, that was a good strategy, I guess, but I ended up, Santa Cruz is a really small county. I, even back home, didn't know how many, never had found somebody who had TB. So given the fact that Edmonton is a 1 million person city, Santa Cruz is about 60,000, the likelihood that they'd experienced somebody with TB was very low. So when I showed up to the doctor at like on-campus travel clinic, she, you know, I just went up to the nurse and was like, oh, I need a refill for my TB medication. And she ended up taking all my tests, taking my papers, and left the room. And I think I sat in that room for around 40 minutes before a doctor came back in. And the doctor basically she had never seen or had any documentation of an active TB patient at UC Santa Cruz before. So she was pretty unsure of how to deal with it. But I told her that, I had all these letters from doctors and I knew what to do. And she was really receptive to all the information. And together we sort of made like a treatment plan. And in doing so, she contacted the public health nurse, found me a pulmonologist. All of these doctors, you know, this team I had developed in the US was great. Like they came to me with appointments. They helped me organize appointments. When I first moved here, I didn't have a car, so they were all so supportive of the fact. But my campus doctor, I would say, went way above and beyond what I ever expected, because she would meet with me on a weekly basis. She would literally go and learn things about TB on her own and then tell me about them after the fact and be like, oh, like, does this happen to you? Because XYZ said that like somebody with your past history or your past treatment, like, could be experiencing this. So it was really reassuring, again, to know that I found a doctor who wanted me to be better, or like really cared about me as a person and maybe not just me as like a patient. Yeah, so all in all, I would say I was really lucky. I had a great medical experience, and I think that was largely due to the fact that I had great doctors who were kind, compassionate, and took time to talk to me as a person and not just somebody who is a patient or a public health risk. Another reason that I probably had such a good experience was that I bypassed the primary healthcare system in Canada entirely, going directly from travel clinic to TB clinic. But I do acknowledge the fact that that's not the case for a lot of other people who have TB or who have had TB, because that initial doctor's appointment or getting diagnosed or getting the tests done is like your first hurdle to getting care. But on that same note, there were a lot of medical or non-directly medical things that really affected me in terms of stigma or how people saw me after I had TB. So first, once I told all my friends, my family, that I had TB, most people were more concerned about their own well-being and not so much mine, which I understand, but at the same time, it really makes you feel like you're the problem when, I did nothing wrong. I couldn't even tell you where I got TB. No doctor could tell me. It was encoded and is unique to where I'm from, so they haven't seen that genome code before. So that was really hard to deal with when people were like, oh, like, do I have to get, like, oh, am I gonna get sick? Before they would ask me, oh, like, are you doing okay? And then I also had a bunch of specialists who would make really weird comments. So for example, when I was getting my bronchoscopy, there was a small delay in like getting the computer turned on. So I'm talking to the doctor who's supposed to do this. He looks at me, he's like, were you really born in Canada? He's like, because you have lungs like somebody who was born in India, which, okay, I am Indian origin, but it was a really inappropriate comment at the time, considering that I'm getting all drugged up to get a tube shoved down my throat. But yeah, so and then I also went to an allergist because I was experiencing hives all over my body from the TB medication. Well, not from the TB medication, but I likely developed an allergy from the TB medication. And he was like, oh, I'm from Africa. I know TB. You don't have a problem. You can just continue about your life. And I told him that if I was looking for a TB opinion, I would have gone to my TB doctors. But, all in all, that, these two very high level specialists really just, didn't give me the time of day. And I would say those were like the worst sort of specialist moments. And then when I came to the US, I was actually denied housing on campus originally because I couldn't move in at the appropriate time because I had to finish my intensive care in Canada, or at least I was advised to finish it there. And the doctor, it was very strange that the reason I found out I had TB was for UC Santa Cruz, and then UC Santa Cruz is telling me that you can't get housing on campus because you have TB. So I ultimately had to reach out to like various different faculty and supervisors of my department, and with their support, I was able to convince the housing department that like this isn't my own fault. I could come and make other people sick if they really wanted, but I shouldn't be penalized for following the rules and getting tests done. And then there were a bunch of like small medical things where I had to carry around a letter from the Department of Public Health that didn't disclose what disease I had, but I had to tell like the dentist that I had TB, so I would give them this letter. This letter was just very strange, where it was basically saying that I was monitored. I am being monitored by the public health department for an undisclosed disease, and I pose no public health risks, which sometimes sounds worse, the fact that I have to hand in this letter. But I had to hand it in to a couple different doctors. And I still have to sometimes carry that letter if I find a new doctor or go to a new clinic, because I do have to click that I have had TB in the past. And then, like, the last note, given all of this and my experience as a whole, the main thing that I want to push towards the medical community is the fact that, you know, a lot of the patients are in a weird headspace. You think you're dying, you know, at least somebody who was born in Canada would never experience TB or didn't know much about TB. You know, I thought I was dying, based off what I had seen in the media and on the news. So you're in a really weird space where you feel like you have to keep everything secret, and you're like, you've done something really wrong. And it's important to be really conscious of the fact that this is sort of their headspace and give them the time to ask questions. A lot of them are also going on, like, you know, have other areas that have been impacted, like their financial situation, some friends or family. So being patient and compassionate at the end of the day is, you know, the most important thing. And I would say that my medical team did this. They even had sent a social worker to talk to me to make sure that all of these other areas of my life were in order so that I could just focus on getting better and not need to focus on anything else. So I have been like TB free for about a year, but I'm still pretty engaged with the TB community, which is how I found out about this event. And then I'm working with like a couple other, you know, advocacy organizations for, you know, to spread awareness about TB just to the general population, but also deal with like more specific TB problems like access to drugs and stuff. But I think that that was all I was going to say. Yes, thanks.
Monica, thank you so much for sharing your story. It was really moving, and we're really appreciative of the opportunity to listen and learn from your experience as it relates to just navigating the health system, the importance of survivor-centered care, and also culturally sensitive care. In addition to that, I think it was really interesting to hear about a positive experience that you had with your provider at a TB clinic. I think that's also really important to address, because I think a lot of us on this call really care about making sure that experience, you know, is supported. And so it was powerful to hear that. Next, we will be discussing what it can look like to create an inclusive communications campaign for latent TB infection with Dr. John Parmer. Dr. John Parmer is a health communications specialist at the National Center for HIV and AIDS, Viral Hepatitis, STD, and TB Prevention for the Division of Tuberculosis Elimination at the Centers for Disease Control and Prevention.
Well, thank you so much, Chibo, and thank you to all for allowing me this opportunity to be a part of this great panel and event, and look forward to sharing with you some information about how CDC's Division of TB Elimination created an inclusive communications campaign for latent TB infection. So the campaign I'm going to be talking about today is the Think, Test, Treat TB campaign. And its focus was on increasing testing and treatment for latent TB infection. I'll probably be slipping into saying LTBI for sake of time. And the communications goal was to position LTBI as a priority health issue for Asians in the United States, as well as among populations most at risk for TB and the healthcare providers who serve them. So we wanted to raise awareness about LTBI risk and the link between infection and disease by addressing misperceptions, decreasing stigma, and encouraging latent TB infection testing and treatment. We want to increase awareness of treatment options for LTBI, specifically the shorter treatment regimens that have become available over the past few years, and encourage providers to test and treat LTBI among populations at risk. So this was a multi-year project, and what you're seeing here is a 3-year high-level project timeline. So we really started this back in 2019 into 2020, our first year, where we did formative research and evaluation with our intended audiences. So I'll describe this a little bit more, but basically this was focus groups with both consumer audiences and healthcare provider audiences. And at this early stage, we were conducting focus groups with people born in a lot of the countries that Dr. Higashi explained, the countries that contribute the most cases TB cases to the U.S. So these included China, India, Vietnam, the Philippines, Mexico, and Guatemala. And so we learned a lot about their awareness and knowledge around TB misperceptions, and that really helped us move into the second year's activity where we were developing the campaign. And so we took what we heard there and developed draft messages and materials for 3 different campaign concepts. And then we came back and this time had a narrower focus to our priority audiences and conducted focus groups with individuals born in the Philippines and Vietnam and now living in the US, and to get their reactions and see which campaign concept was the most, that resonated the most, and did a good job of conveying information. And then finally, in the third year, we actually implemented the campaign. And so we really kind of launched things in the weeks leading up to World TB Day in March 2022, launching the campaign website, purchasing paid media buys, and really, focusing on distributing and implementing all that we had worked to create. So stepping back to that first year's activity with the focus groups with consumer audiences, just some top level insights around awareness and knowledge. We heard that individuals at risk for TB are aware of TB and have some knowledge, mainly related to how serious and contagious it is and primary symptoms, i.e. coughing. There is very little awareness across all groups that TB can be in an inactive form or latent. So there's confusion around the fact that LTBI is not contagious until it turns into TB disease. And this was all happening. We initially had planned to do these focus groups in person, but as things progressed into 2020, COVID-19 really started to impact things around March, and we pivoted to virtual focus groups. And we did hear that the COVID-19 environment, it was affecting attitudes on health concerns, and specifically around respiratory diseases and communications around public health and infectious diseases, and what was being heard and listened to and trusted during that time. Some of the barriers that we heard from these consumer audiences is that there persist misperceptions about TB testing or vaccinations. Most participants do not know you can have TB even if you've been vaccinated, or know that TB vaccine could weaken over time. We heard some issues around cultural factors and pride, and participants expressing a strong sense of their culture and resisting messages that really kind of separates out their culture or their country of birth, out from others in a way that's maybe stigmatizing or negative. Some potential motivators for increasing awareness and testing and treatment of LTBI. We heard, emphasizing the notion of family safety, that thinking about TB, asking about TB, and taking action can prevent the spread of a deadly and dreadful disease around loved ones. This is a good motivator. TB's prevalence in certain communities and the potential for hidden LTBI are also motivating facts that we wanted to make sure we relayed in our messaging. And ease of treatment and low-cost options is potentially a good motivator. So here is a simple table that we summarized what we heard across these different focus groups about level of concern around TB. So each of these columns represents the country of origin that we organized our focus groups around. So China, India, Philippines, Vietnam, Guatemala, and Mexico. And so here we'll say that, you can see that for most of these groups, there was mostly not concerned personally about TB. And the only one that maybe that's a bit of an outlier is the group of Vietnamese-born participants, and they expressed being mostly concerned personally about TB, and then kind of a bit of a more even split for Filipinos. And then broadening that out to concern at the community level, much the same story, mostly not concerned, but for the Vietnamese individuals now living in the U.S., there still was concern about TB in their communities here in the U.S. And you know, hearing a little bit more from some of the participants, they expressed, you know, some personal experiences with loved ones having TB and seeing people suffer with TB in their communities in Vietnam, and having that kind of carry over here into the U.S. So we saw that in those communities. We conducted in-depth interviews and focus groups with healthcare providers, and what we heard around awareness and knowledge. Just a few highlights here. Physicians were readily mentioned that the biggest indicator of someone at risk for TB was if they were from a country with high TB prevalence, while nurses tended to focus or think more about the highest risk being for immunocompromised individuals. Most providers who said they recommended LTBI treatment were at least somewhat familiar with the shorter treatment regimens, but acknowledged that treatment adherence is a challenge. Some potential barriers. We heard that that the perceptions among many providers of the prevalence of TB and LTBI in their practice is low. Challenges with their patients' mindset that stem from cultural factors, things like stigma, or maybe having notions that it's associated with sanitation or things like that. And then environmental and structural barriers that just competing interests for time, for doctors to have that time with patients to talk about TB. Some motivators would be messages that tie testing for LTBI as a way to help curb the spread of TB, particularly among vulnerable patient populations. They wanted messages to have a clear call to action, and they asked for and told us it would be helpful to have screening tools and education materials for patients to help kind of ease that burden of patient education when they don't have time, and specifically having different in-language patient education material options. So the campaign that draft concept that we created that had the resonated the most was the think, test, treat TB concept. And so again, we got this was the second round of focus groups with consumer audiences, those born in Vietnam and the Philippines, but living in the US. And they told us that the Think, Test, Treat TB campaign was the most appealing and motivating concept of the three. It seemed like it was intended to be for everyone. They felt that it kind of hit that balance of being able to see themselves in the campaign concept, yet it didn't feel too overtly focused on Asian people specifically. They indicated that they would be likely to share it with others, which was important to us, and to share as must have give confidence that the information is accurate and important, and the concept did that. So in a bit, I'm going to show you the PSA video that we developed for Think, Test, Treat TB, but I'll just refer to what we heard around showing a draft version of that to these audiences. They really like that it features, you'll see that it features a question and answer kind of telehealth session between a healthcare provider and a patient. And they thought that question and answer format was very realistic, familiar, and easy to follow. And they can imagine having that kind of conversation with a doctor, and having that focus on the doctor was effective. The tagline is simple and useful. In fact, it is a call to action in itself, a think, test, and treat TB. And it's a good example of behavior modeling, which is one of the reasons participants liked it. And it presents the information in a simple way that patients can think about and prepare for asking their provider questions about TB. So just a bit more about the kind of the campaign overview for Think, Test, Treat TB. Our priority populations, we focused on people born in the Philippines and Vietnam, and healthcare providers serving those populations. We had the resources to focus on two markets, and those were Seattle, Washington, and Los Angeles, California. And so we worked with partners in those markets to distribute messages and materials on the ground in those communities, but also our digital placements in newspaper and TV placements were targeted to those markets. So those were the markets we focused on, but our information, our website was available through, across the nation, and people can order any of our materials from the CDC warehouse, and we've seen a lot of people indeed doing that. Some of our channels and partners, to get out for our implementation and distribution, we used, of course, the web, social media, our own CDC social media channels, television in those markets that I mentioned earlier, and print newspapers, in-language print newspapers, putting ads in those. We did out-of-home placements, so in shopping centers, supermarkets, and clinics in the Seattle and Los Angeles markets, areas where there was hopefully high visibility and density of our priority audiences, and partnering with community-based organizations and professional medical associations. So here I hope you will be able to see and hear this brief 30-second PSA that I described earlier.
Hi, Dr. Lopez. My aunt said I should ask about tuberculosis testing. Could I have TB if I don't feel sick?
TB can live in your body for years without symptoms. This is called inactive TB or latent TB infection. That can develop into TB disease, which can make you sick and spread to others. TB hides in plain sight. Millions of Americans don't know they have it.
How can I keep my family safe?
The only way to know is by getting tested. Let's schedule an appointment.
Great. Thanks.
And so that we placed that on YouTube and on our campaign website, and tried to promote traffic to our campaign website and to that video throughout our implementation. Here is just an overview of some of our graphics and messages to give you a better sense of what we distributed. And so this top row is in English, which was the preferred language for our Filipino audiences, and then Vietnamese in the row to the bottom. So you can see here some of the messages that we heard in our formative research and wanted to make sure that we drew out throughout our materials, emphasizing this notion that TB can be hidden. You can have a form of it that you don't, that's no symptoms, and it's in plain sight. The notion of protecting your family. So those were some of the messages we tried to thread throughout. We, as part of our efforts, we developed 5 new education materials. This first one here on the right is a clinic poster, designed, intended to be, can be distributed from our CDC warehouse in a variety of sizes, and it's glossy, high quality print, and to be hung up in a clinic or office. We developed 2 fact sheets, 2 conversation guides, one for how to help healthcare providers talk to patients, and one for helping patients talk to healthcare providers. And these materials are all available in Chinese, English, Ilocano, Marshallese, Spanish, Tagalog, and Vietnamese, available for download or order through the CDC warehouse. And that is the URL for ordering any or all of these materials. So more about our implementation and our channels that we use to reach our priority audiences. I mentioned out-of-home placements. And so here are some pictures depicting that. You can see in the top left a 3-panel LED truck with our graphics and messages going around communities, areas like this Asian market shown here, to hopefully reach large numbers of our intended audience. These banners are ceiling posters in a grocery store, and then a LED screen that's on the main entrance and sign of a shopping plaza. Of course, we use social media, and here are screenshots of our using our CDC TB social Facebook accounts. And that middle example is embedding a Vietnamese video directly into there. Digital placements was a big part of what we did, and our large part of our media buys and budget. And so you can see examples here of that banner, the horizontal banner at the top, Washington Post. The one on the right is a in-language website with a banner on the right, and then YouTube placements. We purchased airtime in our 2 markets of LA and Seattle to actually have our ad or our PSA placed on those television channels. In addition to what we purchased, we were able to secure some donated time as well, which really helped. We had ads placed in language newspapers, and you can see full color and full page ads. We had some success securing some earned media, and we focused around two kind of landmark events, and that was World TB Day in March, March 24th, and in the month of May, which is Asian American and Pacific Islander Heritage Month. So this example in the top or center left is Dr. Higashi, who's a co-panelist here today, and on Skylink TV, great interview. And you can see another example of a TV Crossings TV interview below in Seattle, and then to the right, in language newspaper placement. Just a few lessons or recommendations from our experience with securing earned media. You know, it's important to provide local spokespeople who can talk about the situation in their communities, and to give the media outlets comprehensive background information that's accurate to help secure that story. So just further emphasize here, you know, using local TB data and Asian-specific TB data is really what they're looking for, and kind of the angle and hook that we needed to get that earned placement. Working with reputable organizations or spokespeople adds credibility to the campaign. So points of view from the public health departments, well-recognized providers, that's what the reporters are hoping for and looking for. And it's important to translate key messages and fact sheets for the media to ensure accuracy. Asian American media outlets might not be familiar with the topic and really prefer to have that in-language resources that they can just use verbatim during coverage. And we know that TB can be kind of a complex issue, and explaining it in a clear way is maybe a lot to ask and difficult for news outlets who are, you know, maybe just focused on TB just briefly and moving on to the next thing. So that campaign, our paid media efforts ended around fall of last year, 2022. We had the resources to continue and expand our efforts to reach healthcare providers. We weren't able to continue those efforts to reach consumer audiences, but for healthcare providers this year, we've really expanded our overall reach to providers with increased investment and a revised channel mix to reach them. So we are actually weeks away from finalizing our final report for the year's activity, but we're starting to see kind of what our overall metrics were, and it's really looking like these changes that we've made from last year to this year really were the right, you know, they were very successful. I think we're seeing about 8.6 million impressions overall. Our click-through rates, which is an important metric for campaigns like this, showed, I think, about 200% increase from last year, and so we're happy with what we're seeing and what we did with the resources we had. We maintain an increased mix of partners and provider platforms like Medscape, American Family Physician. We had larger investments in specific geographic markets, so areas with high TB incidences include areas in Florida, New York, California, and Texas. So using the geo-targeting and location tools to really heavy up in those areas, but still going after a national audience at the same time. We evolved our email strategy and worked with a new partner, Bulletin Healthcare, where Bulletin Healthcare is kind of an organizer or a conglomerate of large email distribution lists that go out to healthcare providers, and we saw a much improved uptake of those in that channel. We saw an increased overall reach and efficiency using what is called programmatic advertising, which is you really are following your target audience where they go or are likely to go online. And so that's a little different than trying to just purchase placement on a specific website like Medscape, but rather a more fluid programmatic advertising where it really tries to track and predict where your audience is going across the web to maybe non-health related websites. And that seemed to work really well. And we introduced new formats like in-feed native ads, where, you know, I'm sure you're familiar with, you're reading something on the web and They're in the center there in the text, kind of formatted to look in the same look and feel as the content overall that you're interested in, and that native ad is right there. And it looks like that may be a nice change in addition to using just the digital banners, which by now a lot of audiences have kind of banner blindness where they don't really see that or pay attention to them. We added LinkedIn as a digital channel for provider audiences. This seemed to have done really well. I think we were really surprised and pleased with how well LinkedIn performed for us as a channel, and look forward to using that in the future. So I'll end it there, and here are the some resources, campaign website, where to order materials, and contact information.
Thank you, Dr. Palmer, for sharing this helpful information about the CDC's inclusive Think, Test, Treat TB communications campaign and its effectiveness in tailoring messaging to address both knowledge gaps and cultural differences to reach priority audiences. This concludes the speaker presentations for today's webinar, so we'll now move forward to a quick panel discussion with our speakers to provide insight on how to make steps for positive change, and then we'll open it up for Q&A with the participants. At this point, I'll pass it off to Chibo.
Thank you, Deia. So my first question is to Dr. Julie Higashi at LA County Department of Public Health. And my question, my question to Dr. Higashi is, are there any advancements in medical or diagnostic technologies that hold promise for improving TB detection, treatment, or prevention? And how do these advancements align with the goal of reducing TB incidence in the U.S. Asian and Asian American population?
You know, I think TB is one of the faster moving areas, more recently in diagnostics and therapeutics for TB treatment. So for TB treatment for disease, the regimens are now shorter. We've gone from 18 to 24 months for drug-resistant TB to 6 to 12. We're taking regular pan-sensitive TB, drug-susceptible TB, treatment durations from 6 to 4 months. The LTBI, the latent TB treatment regimens, have also improved, and we've gone from like 9 months to 3 to 4 months, and even there may be a 1 month or 6 week regimens that are really on the horizon. So we're really, really getting to the point where TB can be much less of an imposition on patients' time. The treatments are more tolerable, or if they're shorter, people understand that they can take more drugs or maybe a little bit more difficult regimen for a shorter period of time. But I really think, and I want to say that Monica really hit the nail on the head when she said, you got to talk to your physician, or your team, and you need to know what your choices are. And it's really about delivering this patient-based care and having collective decision-making about what you want to do. So diagnostically, we've done better with the blood tests that exclude the issue of the BCG vaccine. That's been around for a long time, but getting that diagnostic to the right populations has been challenging, and we've made a lot of progress. I think a little bit of, we've made some progress in the recent decades. So I just want to be hopeful about things. We experienced some interesting challenges in the United States in that, because of barriers to regulation, some of the newer diagnostics don't necessarily make it to us in the same time frame that they make to the rest of the world. And so that's where we're looking for patient advocates, because the survivors are so effective at showing how this harrowing experience has impacted their lives. We need the best tools, the best drugs to get to our populations that really need them. And so that's, I think, really key. And the last thing I'm really hopeful about is the vaccine sort of horizon. One of the silver linings of COVID is the mRNA science that has come along. And we really actually have some TB vaccines in trial right now, which is super, super exciting. So a lot of hopeful interventions and science on the horizon, but we still need to do better.
Thank you.
Thank you, Dr. Higashi. This next question is for Zinnia and Dr. Tang. Could you share some examples of specific actions or interventions that can be informed by the deepened understanding of health disparities gained through disaggregated data collection? And how can this knowledge be translated into tangible improvements in patient care and community health outcomes?
I can go first and then I'll pass the mic to you, Dr. Tang. Yes, I think I kind of highlighted briefly on one of the ways that we were able to create a new partnership with a community-based organization. So I think having that data to kind of highlight to you within your patient population what disparities exist and communicating that not only with your team, your organizational staff, your leadership team, but also how you can think of ways to use that data in a effective and honorable way in the community is one aspect. And then Dr. Tang. Oh, I don't think we can hear you very well.
Oh, hello.
Yes.
Okay. Zinnia, I think you were referring to the COVID data disaggregation and seeing that the Vietnamese community in San Francisco seemed to be disproportionately affected, even compared to like our primary Chinese community, and how we had some funding opportunity from the state to work with CBOs, and we really preferentially sought out working with the Vietnamese group in the Tenderloin neighborhood. So that definitely, we had that data at the right time and felt like we were allocating the resources appropriately. And I think similar, like with the Hep B study and seeing that certain Chinese immigrants from Fujian province, for instance, were disproportionately affected, could be used to reach out to some of the Fujianese organizations in the New York Chinatown there to do some creative outreach strategy. So not necessarily in a conventional healthcare setting context, but with some of the other leaders in the community who may be influential and help to raise awareness of the importance of testing and liver cancer prevention and things like that. So I think the main effect is not maybe as much direct clinic care related, because as a physician, we see patients with all sorts of backgrounds. And I think it's probably easier as a physician to have more simple rules. But as an organization in the community, it helps us figure out what are key alliances to help reduce health disparities, and working with non-conventional leaders like religious leaders or housing-based organizations and things like that.
Thank you. Thank you, Dr. Tang. Thank you, Zinnia. Chibo, did you have a question for Monica?
I do. Monica, I really appreciate your call for patience and compassion from the medical community. And based on your journey, could you just share some actions, some examples that medical professionals could take to ensure that their patients feel understood and supported?
Yeah, so I think that my doctor, Dr. Parhar, that I worked with first, she was probably the best at it. And number one, giving me like realistic expectations. So she told me that like you have a problem, you have holes in your lungs. So like if it's not TB, it's something worse. Which, okay, maybe was like a little, she didn't say it like that. It was like a little nicer than that. But saying things that give you realistic expectations of what to expect. And then that goes for even when you're giving tests or prescribing what to do, you like talk through, well, what are the side effects of these? Like, what are things you should look for? Because sometimes you don't even know what you're supposed, like, what is a side effect? So I went through a whole year not realizing that me throwing up was a side effect of my medication and wasn't just stress. So I think that it's important that you explain, like, what are the problems that you could face, or, when to contact your doctor, because sometimes I know as a patient, you don't want to like overburden your doctor. So giving them space to be like, well, if this happens, like you should contact me, or you should feel free to like, keep this like a two-way communication, especially since you're supposed to have like a long-term like a long-term relationship with this doctor, at least for the duration of your care. I think that's really important that you keep that like two-way communication open.
Thank you, Monica. Deia, go ahead.
I have one last question here for Dr. Parmer. The motivations that you've identified, such as family safety and the potential hidden nature of LTBI, are compelling. Can you elaborate on how the campaign intends to leverage these motivators to encourage testing and treatment?
Sure. Yeah, that was you know, an insight that was really helpful to have early on in that audience research. And I hope we were successful. I think we really put that at the very top and made that a central part of our development, for our materials, our graphics, and our messaging. So, you know, you saw on some of our graphics that we emphasized, you know, a lot of our visual imagery was of families, and the notion of protecting your families. And as far as about, you know, there's being these two forms, latent and disease, I think, you know, we pretty much started off every fact sheet or blurb of information that we put out to lay that out first, hopefully succinctly and clearly, that you know, you could have this form of TB that you don't know you have, you don't have any symptoms, but it could go on to develop into disease and could impact your health and those around you, your loved ones. And then, like with the video, the PSA video, we you know, we didn't have much time. It's a 30-second video, but we really tried to show, like, if, you know, I know you saw it briefly, but we zoomed in on a couple of family photos showing multi-generation. So the grandparents and the grandkids and the parents, and you know, and the daughter comes in at the end, and hopefully kind of reinforcing that image of protecting your loved ones. So I think we really tried to keep it that insight central to everything that we produced.
Thank you. At this point, we will open it up to some questions from the attendees that we have here. Chibo, do you want to take the first question?
Well, I want to be aware of time, and I do see here that we have several questions in the Q&A, and I think some of them have been answered here. And I think that I think we could probably answer a few of these questions here. And I think the first one that I see is important is, you know, one of the questions that we have from is, why do you think the US born Asian rates are so much lower than other ethnic groups? And Dr. Higashi's response was that I think that the difference in US born rate is comparable to the Latinx and Hispanic rate. The other race, ethnic groups, case rates are higher, except for the white population. And I think the incidence of TB in Asians is really tied to reactivation of non-US born individuals. The other groups, Black, Native Hawaiian, Pacific Islander, Alaska Native, American Indian populations have higher rates, which represent health disparities. We have another question here that says, are the letters in the various languages available to use for NEMS? And I think Zinnia has offered her contact information for you all to reach out to her. One other question that we have here is also from Wendy Inuye, who asked about the data collection instruments for latent TB infection. One, do they support case management? And two, are they open source and or potentially available for other jurisdictions to adapt for their own use? So I'll open that up to our panelists if any of you want to respond to that question.
Well, I can answer from a health department perspective. There are tools, they tend to be paper-based, which make them a little unwieldy. Some of them do include or involve the patient, which might be helpful. And so that could be worked into the workflow. The patient can be, you know, helping with the documentation. And so it depends on, and those are pretty much available in online. I think the Think Test Treat TB campaign does have some of those tools, and there are some other websites that do have those tools. But from the standpoint of an EHR, maybe, I don't know if Dr. Tang or Zinnia have other thoughts, but it can be a little bit more challenging in those situations.
We have two main templates. One is the risk assessment, and then the other one is what we call like the LTBI treatment info template. So the risk assessment, I think everyone uses this widely, but it's primarily to help providers decide whether they should order a test. We haven't had great outcomes with the use of our EHR risk assessment for Epic. We're actually thinking of putting this on to the patient, like the patient forms that they have to fill out annually, rather than the provider as something else that they have to ask during their busy visit. And we hope that this will help task shift and activate the patient to ask about these things. And then it would alert the provider if they answer yes to any of the risk questions. And then the treatment info template was mainly because we wanted to track treatment discussions. If a patient declined treatment after the provider had presented risks and benefits to them versus how much of the time did they actually prescribe a medication, and also to track completion or discontinuation due to side effect. So that is somewhat record keeping, just so we can track outcomes. However, sometimes these templates aren't completed uniformly by every provider, so that's a limitation to their use. So we've been trying to find other creative ways while we're switching to Epic.
Thank you, Dr. Tane, and thank you, Dr. Higashi. I think that answers one of the questions, the additional question we have about treatment and how to support our patients. We have another question here about, or just more of I think, a great topic for discussion, which is we have had several instances recently with Asian individuals who refuse to take TB or LTBI medications because they either feel it is too many medications or they don't trust Western medicine. What recommendations can you offer to help us in these types of scenarios? And I appreciate that question. I think it's a question that all of us can all the panelists can kind of address in different ways. But I'll open it up to any panelists who'd like to address that.
I think trust is kind of a fundamental thing when you're having the discussion. That's why I think primary care can play an important role, especially when a patient has had a primary care relationship with a provider for a while. I feel like the patients that trust me the most are ones where I've known them for some time, or I've helped them through some sort of problem before. Like they know that I can be helpful to them. And so, and when it comes to talking about other issues, whether it be TB, if they already have that trust in me, then it isn't that hard of a sell. However, if it's someone I'm meeting, only a couple times and I don't even speak the same language as them, I'm using an interpreter, it can be a little bit harder. I find that the 4 months of rifampin is probably the easiest, the most digestible regimen to our patient population because it's 4 months instead of 6 or 9, but it's also just taking like one type of medication once a day rather than 3-HP is actually 10 pills once a week for 12 weeks. And then I think some strategies our providers have used is really putting the treatment discussion in the context of family and protecting their family, community members, things like that. So some patients may not really be driven by like preventing reactivation of infection in themselves because they don't feel bad anyway. But if you put it into the context of protecting their loved ones in case the infection can reactivate and cause symptoms in the future and spread to others, then they are more amenable to take the 4 months of treatment.
Thank you, Dr. Tane. We have a comment here. Oh, yes, Dr. Higashi.
I think one thing is just you sometimes have to have more than one conversation. So I think that's why primary care is really advantageous because you're supposed to be having a continuous relationship. So for us at the health department, where we're supposed to just be dealing with TB, that may not allow that type of longitudinal conversation to happen. But sometimes it takes a while. And I think you're right, Dr. Tang, with the trust. So I think it is, as long as the person has said, no, I don't want you to talk about this with you ever again, I mean, to revisit is, I think, a really good strategy.
Thank you both. We have a comment here from Angela, just kind of going back into, really appreciating Monica for bravely sharing her experience. She says, we learn here from the patient perspective on how to provide more compassionate care. And I think this is all kind of holistically, this panel discussion is really, I think, reaching out and kind of touching on, the importance of building these bridges to health equity. And what does that look like as we're, through the various facets of addressing TB within our Asian American population. I'm gonna, just for the sake of time, I'm gonna get to our closing, but I really want to thank all of the panelists for joining us in today's conversation, and for your partnership and for just your, guidance in having this dialogue. I particularly also want to just appreciate our heartfelt gratitude extends to the Curry Center for Tuberculosis and Heartland as well as every guest speaker who has shared their expertise and passion here and stories. To our participants, your engagement today is very much a testament to how, to making sure that we can eliminate TB, that we can also encourage these dialogues about stigma and how important it is for us to have, dialogue around Asians and Asian Americans impacted by tuberculosis.